Thank you for the nice introduction. Uh, First of all, let me thank to Dr. Georgina sir for giving us the opportunity to say the nephrology perspective on granulomatosis with polyangiitis. So, as per the 2012 chapter classification, the granulomatosis polyangiitis comes under ANGA-associated small vessel vasculitis. Other was small vessel vasculitis in this is microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. So, the previous name of granulomatosis polyangiitis was beginner's granulomatosis. This is Mr. Frederick Wegener, as already described. So, granulomatosis polyangiitis, the core features are the post-immune, that is necrotized post-immune necrotizing vasculitis of the small vessels, and the granulomatous inflammation in the upper and lower respiratory tract. Glomerulonephritis is there in glomerulonephritis will be there in 80% of the cases, and around 80% there will be PR3 ANGA will be positive. So peak incidence is in the 5th to 7th decade of life and equal male to female ratio. On to the pathogenesis. There will be a genetic predisposition may be there. So once there is a any infections, a trigger is there. These ANGA antigens, which are usually seen in the primary granules of the neutrophils, they come to the surface of the neutrophils, and the neutrophils get primed. So the ANGA antibodies, anti-neutrophil replacement antibodies, which are seen in the circulation, will come attached to these antigens, and later these neutrophils attached to the vascular endothelium. There will be neutrophil degranulation, and neutrophil extracellular traps will be there. Further inflammatory cytokine release and activation will be there. And also there will be alternate pathway, complement pathway will be there. So these C5 anaphylatoxin will be attached to the C5 receptor, leading to further priming of the neutrophils. And this comes as a loop. The major clinical manifestation, the GPA, it is a multi-systemic disease, and there will be constitutional symptoms like fever, malaise, weight loss, arthralgia. Such symptoms will be predominant in 80% of the cases and will be present maybe prior to weeks to months before the specific organ symptoms. So upper respiratory tract is involved in majority of the cases like sinusitis, otitis media, ulcerations, nasal perforations, saddle nose dyspnea. Sometimes subglottic stenosis may be there in 16% of the cases. Lower respiratory tract involvement in the form of diffuse alveolar hemorrhage, nodules, cavity lesions. In 80% of cases, renal involvement will be there in the form of RPGN, and ocular and cutaneous manifestations also may be there, like palpal purpura. And some cases, there can be mononeuritis multiplexa in nervous system. So this was a study, it was done in St. John's, Karnataka. It was showed that there will be constitutional symptoms in 80% of the cases, and predominantly lower respiratory and involvement was there. In the Western studies, upper respiratory involvement was there, but it was not seen in South Indian population. And this was a X-ray. So patient was admitted. Already patient was diagnosed to have a granulomatosis, and 2 days after patient had a diffuse alveolar hemorrhage that you can see in the diagram of the X-ray. So it's a CT finding of the venous granulomatosis where the patient there is nodules are there, cavity lesions are there. Re-enrollment is a critical determinant of predicting mortality. So it is said that patients who present with GFR less than 50, they carry a 50% risk of death or kidney failure at 5 years, needing to early diagnosis and treatment of the patient. So re-enrollment is a critical determinant factor in predicting the mortality. So typical renal presentation will be in the form of a rapidly progressive glomerulonephritis, that is decline in the renal functions over weeks to months, accompanied by a subnephrotic range proteinuria, microscopic hematuria, and hypertension. Urine analysis will be showing RBC cast rise, and there will be a rise in creatinine. So when should we suspect granulomatosis with polyangiitis? In the renal cases, there will be RPGN picture will be there. The pulmonary involvement, dyspnea, X-ray showing alveolar hemorrhage, findings, X-ray findings, then constitutive symptoms. Sometimes there will be unexplained renal urine sediments. So Anga antibodies, that's are circulating anti-neutrophilic cytoplasmic antibodies. So they target the antigens, that is proteinase R3 antigens, or the myeloperoxidase antigens, which are seen in the primary granules of the neutrophils. So in the GPA, that is venous granulomatosis, the PR3 Anga will be positive in 80% of the cases, NBO positive in 15% of the cases, and 5 to 10% the Anga may be negative. Whereas in microscopic polyangiitis, 70% will be MBO positive. So diagnosis of the granulomatosis polyangiitis is based on the clinical features. Then 80% cases there may be PR3 Anga positive, and if possible, the tissue biopsy need to be done if patient is stable. And always rule out the other causes, alternative etiologies of RPG. So investigations, urine analysis shows RBCs, hematuria, proteinuria. There can be raised USR, leukocytosis, thrombocytosis, and specific to the cases, we should send ANA, and anti-GBM should be sent in cases suspecting alveolar hemorrhage. C3 should be done, and Hep C patients suspecting cryoglobulinemia should be sent, and HBCG should be sent. And X-ray, fine. If you are suspecting any diffuse alveolar hemorrhage, cavities, CT tests also need to be sent, and tissue biopsy need to be done based on the cases. So always rule out RPGN. Anti-GBM disease need to be ruled out. In specific to the cases, lupus nephritis need to be ruled out, or IRGN, or especially in Hep C cases, cryoglobulinemia need to be sent. Imaging evaluation, renal ultrasound, X-ray is the first line. If you're suspecting any cavitatory or nodules, always do a HRCT thorax. And this is the finding of HRCT, that the nodules or cavitatory lesions are there. So role of kidney biopsies. So in rapidly worsening cases, we will not wait for the biopsy to start the treatment. So biopsy can be done to kidney, lung, skin, or nerve biopsy. All will show a post-immune necrotizing vasculitis. So this is a biopsy finding, lung finding showing granuloma, the lung histology. So in the kidney biopsy, in the light microscopy, there will be focal segmental necrotizing presenting glomerulonephritis, and there is no immune depositions will be there. And segmental fibrinode necrosis is characteristic, that the fibrin will be intensely stained with red. So it's a light microscope finding showing the crescents are there, and this fibrin deposits can be seen. The fibrin deposits, fibrinode material can be stained in the red. This is a crescents. Immunofluorescence in the Anga, there will be no immune deposits. In anti-GBM, there will be linear deposits and granular deposits in immune complex disease. So, in microscopic polyangiitis, it will be the upper airway and pulmonary nodules are not typically found, and there is no granuloma formation. Re-involvement will be there, and it is more associated with anti-MBO Anga. And in eosinophilic granulomatosis, the asthma and eosinophilia is a predominant symptom, and renal disease is less common and less severe. So coming to the management of granulomatosis polyangiitis, it is in two phases: the induction phase to achieve the remission, and in the maintenance phase to prevent the relapses. So coming to the induction phase, it can be treated with rituximab plus glucocorticoids, or cyclophosphamide with glucocorticoids, or rituximab plus cyclophosphamide plus glucocorticoids. And in indicated cases, plasmapheresis need to be done. So in patients present with markedly declining GFR, that is serum creatinine is more than 4, always you should give cyclophosphamide and glucocorticoids, or you can combine rituximab plus cyclophosphamide plus glucocorticoids. So cyclophosphamide is preferred in all organ-threatening cases. In severe glomerulonephritis, where the creatinine is more than 4, cyclophosphamide need to be given. So rituximab is preferred when there is infertility issues, children's, older patients. In relapsing cases and PR3 Anga cases also, rituximab can be preferred. So in all approaches to induction therapy is combining rituximab and cyclophosphamide. Here, 4 doses of rituximab plus 2 doses of cyclophosphamide along with methylprednisolone pulse was given. But was found that reduced remission in more than 80% of the patients at 6 months, and this allowed to give reduced dose of steroids. So plasmapheresis is indicating severe renal disease. That is, when the creatinine is more than 3.4, when there is associated anti-GBM disease, when there is diffuse alveolar hemorrhage along with hypoxia. In such cases, plasmapheresis need to be done. Then it can be in the cases of diffuse alveolar hemorrhage or anti-GBM disease, a daily plasmapheresis need to be done. And in other cases, with only severe renal involvement, alternate day also can be given. And methylprednisolone pulse is the initial therapy. In severe cases, we should give methylprednisolone pulse that is 500 to 1 gram daily for 3 days, followed by 1 mg per kg to be continued for around 2 to 4 weeks, followed by tapering. And is tapered to 5, prednisolone is tapered to 5 to 10 mg at 6 months. And in Pexos trial, it was found that reduced steroid, it was rapidly steroid in the second week, reduces steroid in the second week, that is from 60 mg to 30 mg from the second week, and showed that it was non-inferior to the other normal steroid regime. So cyclophosphamide, IV cyclophosphamide or oral cyclophosphamide can be given. The accumulated dose will be more in the oral. So IV cyclophosphamide dose is 15 mg per kg per dose every 2 weeks for 3 doses. Then every 3 weeks for 3 to 6 months. Need to be combined with the steroids. So after this RAVE trial and rituximab trial, the rituximab came into the picture of induction therapy of vasculitis. In the RAVE trial, it included both the new and relapsing cases, but it enrolled cases of creatinine of less than 4 milligram per deciliter. So in the RAVE trial, either patient received rituximab or oral cyclophosphamide. It was found that rituximab is non-inferior to cyclophosphamide in inducing the remission. And it was found that in the relapses, the rituximab is superior compared to cyclophosphamide. So in the relapsing cases, as per the RAVE trial, rituximab improved the remission and fewer relapses was seen when compared to the oral cyclophosphamide. In post-hoc analysis of the RAVE study, the complete remission was more in the rituximab compared to the cyclophosphamide group in the PR3 ANGA positive patients. Then came the rituximab trial. It included only new cases, but it included the severe renal disease also. Here the patient received rituximab along with two doses of cyclophosphamide, and either this thing or a patient received only IV cyclophosphamide. So it was found that there was no difference in complete remission at 1 year and 2 years. And later, the Advocate trial showed that in less severe cases, avacapan, which is a selective C5a receptor inhibitor, can be given as an alternative steroids, but it needs further trials need to be there. And maintenance therapy is always required in vasculitis because the relapse rate is around 30 to 50% by 5 years. So we'll diagnose the relapse based on the clinical and pathological evidence and not only by the rise of ANGA titer. So factors which increases the relapse risk for ANGA vasculitis are patients who have already vagus granulomatosis, PR3 ANGA subgroup, those who have extensive disease, more upper respiratory involvement, patients who already have a history of relapse, and when the ANGA is positive at the end of induction phase, there is a rise of ANGA antibodies. It indicates that the ANGA was relapsed. And those who receive lower cyclophosphamide exposure, early steroid withdrawal, all these are increased risk of relapse. So we can give the maintenance either giving rituximab or we can give azathioprine plus low dose steroids. So this is the main recent trial in the maintenance trial. It showed that after cyclophosphamide induction, rituximab group had less lapse rate compared to the azathioprine group. Five major lapse in rituximab, 29 in azathioprine group. The adverse events were similar. So here in the main stand trial, rituximab was given on day zero, then after 2 weeks, then 6 months, 12 months, and 18 months. And only 5% had a major relapse, and 29 in the azathioprine had a relapse. And superiority of rituximab was maintained for 16 months in this trial. Then came the main risk and true trial. So here they compared the fixed dose regimen with the tailored dose regimen. That is, rituximab was we administered based on the reappearance of CD90 count. So it is found that there is no difference in the relapse or adverse events, but the infusion rate could be reduced from 5 to 3. Then the ritaseram trial was there, and this showed that the relapse-free survival was more with the rituximab group. The blue one is rituximab. There was less relapse compared to the azathioprine group. So in the maintenance regimen, rituximab is preferred in the relapsing cases, PR3 patients, older patients, those who want glucose sparing is required. And azathioprine is preferred in low baseline immunoglobulin. And sometimes in hepatitis B reactivation can be there with the rituximab. Such cases also azathioprine may be preferred. Then when to stop maintenance? This is a debatable question. So there was a remain trial which showed that after the cyclosporine steroid injection, patients were either continued with azathioprine prednisolone for 48 months or azathioprine prednisolone for 24 months. So it was found that there is a significant decrease in the major and minor lapses and better renal survival in the continuation group compared to 24 months group. So the duration continuation of maintenance therapy should always be personalized based on the predictors of relapse. The optimal duration of remission therapy as per category is 18 months to 4 years after induction. So when considering the withdrawal of maintenance therapy, the risk of relapse should be considered, and the patient should be informed the need for attention coming to the OP if the symptoms occur. So patients with MBO ANGA patients, they have a low risk of relapse. So the duration of maintenance therapy can be reduced to 18 to 24 months. So the disease activity is being assessed by the Birmingham vasculitis score. There will be 9 categories, 8 organ specific and other one general categories. Based on the scoring, we can find is a major or minor relapse. So as a whole, the 5-year survival is more than 80% with the modern immunosuppression therapy. The relapse rate is 30 to 50%. And when if it is ESRD patient, we should 6 months patient should be in remission before their transplant for a angavasculitis patient. So renal survival, the serum creatinine at the treatment initiates is the main strongest clinical predictor for long-term renal survival. Along with that, the age at presentation is also important. And ANGA positivity at the time of transplantation does not independently increase the recurrence risk. And histopathology based on the burden classification, that is, for if more than 50% have normal glomeruli, their renal survival is more, and the crescents are the survival is less. The sclerotic has the less renal survival. So the key messages in the granulomatosis polyangiitis, we should suspect the disease very early. That is, when there is a renal involvement, plus a respiratory involvement, we can such cases we can confirm with the PR3 ANGA, and if biopsy is possible, we can do the biopsy. And always in severe cases, we should always induce with the cyclophosphamide and plasmapheresis in indicated cases. And always the maintenance is required either with the rituximab or the azathioprine for the sustained remission. Thank